Yeah, for sure. I think our major research project was on GLP-1 receptor agonist in polycythemia vera as well as in MDS. So the main clinical background was how the chronic inflammation can impact the somatic mutations and how it can result in a different stuff. Like some people love that theory, some people does not like that theory at all. But our main background was given the fact GLP-1 agonist, we call glucagon-like peptide receptor agonists like semaglutide, liraglutide, dulaglutide, all these categories are pretty much popular these days. Specifically, they are FDA approved for weight management. For heart, now there's recent evidence showing that it might be used for heart failure exacerbation, but we know it's initially used for glycemic control in type 2 diabetes mellitus. So our main thing was like, as a resident studying, digging down deeper into their mechanism of action, we were interested that there's a preclinical evidence showing that they might impact, specifically in type 2 diabetes mellitus patient, it decreases the risk of MDS as well as myeloproliferative neoplasms. So we wanted to dig down deeper into it, that what is the cause. And there's some preclinical evidence as well as clinical evidence showing that they might have anti-neoplastic and anti-inflammatory effects, and how they usually implement that, for example, there are a lot of pathways they usually modulate, specifically PI3K pathway, AMPK, ERK, they also modulate that particular pathway. Then again, mTOR and phosphoinositol 3 kinase pathway, as I said. So there are multiple pathways where GLP-1 agonist has a potential to act as a drug which increases the apoptosis in our cancer cells, or it decreases the cellular proliferation, and furthermore decreases the clonal burden itself and decreasing chronic inflammation. The recent evidence also showing that specifically in neutrophils, macrophages, and in other NK cells, they are decreasing the expression of NLRP3 inflammasome formation, furthermore decreasing the NF-beta pathways. So all those things were implementing and going towards that direction. They might have some anti-neoplastic activity. So our main goal was to check how does it work in a polycythemia vera population. So we started digging down deeper into it, and in our clinical practice we have seen those patients who are on even polycythemia vera or MDS patient who are taking GLP-1 receptor agonists, they have a very good clinical outcomes as compared to those who are not. So that idea take a deep turn when we dig down and using a big global database, Trinitex database. I will definitely give acknowledgement to them as well. We pick out people from 2010 to 2022 who had a diagnosis of polycythemia vera or MDS. We'll talk about like polycythemia vera first. Polycythemia vera patients who are taking GLP-1 receptor agonists, we follow them up for 3 years till the index point. So index point actually started when the patient had a diagnosis of polycythemia vera and they were started taking GLP-1 receptor agonists. So we followed them up for 3 years. And our main primary clinical outcomes were all-cause mortality, progression to myelofibrosis, and other outcomes included AKI, recurrent hospitalization, ICU admissions. So see the health clonal burden as well, that how they are putting into the healthcare system. So, and as we know, polycythemia vera is kind of a chronic myeloproliferative disorder with high risk of having thromboembolism risk. For example, 30 studies have shown 34 to 42% patient population actually have increased risk of pulmonary embolisms, deep vein thrombosis, and also has increased risk of TIAs, transient ischemic attack, and ischemic strokes. So we want to put that particular part as well in our primary and secondary outcomes. And then they have increased almost 10 to 14% patient population usually transform into myelofibrosis. So we wanted to see these kind of main clinical outcomes, that how does this potential anti-neoplastic and anti-inflammatory effect can be furthermore like how we can evaluate that in the GLP-1 receptor agonists of these GLP-1 receptor agonists in polycythemia vera patients. So we use this Trinitex research database and patients having polycythemia vera diagnosis, taking GLP-1 receptor agonists, follow them up for 3 years. At 3 years, we found out those patients who are on GLP-1 receptor agonists versus those who are not had decreased risk of progression to myelofibrosis, all-cause mortality, decreased risk of hospital admissions, and all those, as well as ICU admissions, and venous thromboembolism, as well as TIA, as I said. So all those things, all our primary as well as secondary outcomes showed a very promising results, like specifically, but again, this is a kind of a retrospective prospective analysis, so this study has limitations as well, given the fact it's a retrospective analysis, so you can't do it with causality, and then on top of it, there's a limited clinical granularity, even though we know that 95% patient population of polycythemia vera, almost 95% have a JAK mutation, but we didn't have a proper mutational data for individual patient because we included almost 4,129 patients in each cohort after propensity score matching. So in order to be very thorough with the propensity score matching as well, we included patients who has 45 different parameters, from their demographics to their comorbidities, including their medications which can impact the mortality, for example, statins, and then aspirin, insulin if they have underlying insulin. So our study showed that those patients who are on GLP-1 receptor agonist has decreased risk of all-cause mortality, decreased risk of having any venous thromboembolism, including PE and DVT, and also decreased risk of having stroke. So that was kind of a pretty much decent result. To further solidify our findings, we did a subgroup analysis. So in those patients, we only picked up type 2 diabetes mellitus patient and who have a diagnosis of polycythemia vera. Either they are taking GLP-1 or they are not. And we also followed them up for 3 years, and the results persisted there as well. And then in order to make sure that, those who are taking GLP-1 receptor agonist or those who are taking metformin, how the difference between those, because both are treating the glucose, right? But in order to be very thorough, we also put the HbA1c mean levels in propensity score matching, so we will be on top of it that is exactly the type 2 diabetes mellitus was well controlled or not. So in subgroup analysis, we also found very promising results. I think this concept we also presented as a separate poster as well, because the concept was same, right? The chronic inflammation decreasing the somatic mutation. In our studies, in our own patient population data, we have some data from CHIP, we have some data from MDS as well, and we saw those who has recurrent whole genome sequencing happening after every month. We saw a decrease in VAF, variant allele frequency of mutated genes was getting decreased, those who were on GLP-1 agonists. That's what kind of both translational as well as our clinical perspective come in. So now how we are moving towards forward to further solidify our findings, with the help of Dr. Massajuski in his lab, we are grafting the patient mice now. We are doing mice study to more translational level to further understand, is it the same pathways we are talking about, or there's another pathways which we haven't explored yet. So we are grafting these mice in 4 different sets. One with polycythemia vera, then CHIP mutation patients, CHIP mutation mice, and then high and low risk MDS. We had the clinical studies in all those things which are showing promising results so far. So that's why we want to see, we are grafted them already with these things, and we are doing the whole genome sequencing kind of pattern in the mice after giving the GLP-1 agonist at 15 days and 30 days. So that's what our next step is, and hopefully we are hopeful to get good results there as well. So far, we know the FDA have approved GLP-1 receptor agonist for heart failure exacerbation. Kind of they are middle of prescribing it, making it as a GDMT part, guideline-directed medical therapy. But the main purpose is the FDA have approved GLP-1 agonist is in type 2 diabetes mellitus patient for the glycemic control. And the second part, GLP-1 agonist used for weight management itself, obviously. So if we find even though the clinical data is evident to do a clinical trial already. So again, this is a retrospective study, so we can't implement that on the basis right now, but I think this is a very good basics and solid foundation to start a clinical trial based on that. So if we find, and if we have, why we are moving toward translation, because we want to understand ourselves, dig down deeper into it, what is the other culprit we are missing here? Otherwise, I think the study itself is, I think, a little bit solidify this need of doing a clinical trial. So I think obviously in order to implement that to the other patients population, the proper clinical trials needed to be done to further assess their safety and efficacy before we implement that retrospective study findings to everything. And again, if you have patient who has a polycythemia vera and have high weight, or those patient who has polycythemia vera have underlying heart failure exacerbation, or patient who have polycythemia vera with type 2 diabetes mellitus, that might be very beneficial for them if they are on GLP-1 receptor agonists, even though approved for something else, because it might have some synergistic impact.